First, I want to welcome you to Orientation for Phoenician Hospice. We are excited to have you here and to give you a little bit of education, orientation. That's what orientation is, a little education about several parts of hospice, of Phoenician hospice, as well as hospices in general, and the regulations and the requirements. So with that, I'll first introduce myself. I'm Nancy Greshel. I am the QAPI director, and that will be QAPI will be explained later on in the orientation. I'm just excited to be here and be with you through this orientation. So, with no further ado, I am going to discuss the mission statement and the vision. The mission and vision statements explain the heart of what the agency is about, what Phoenician Hospice is about, where Dr. Levy and Valerie Woodworthy and Phil Gallinero, where they'd like it to go. They are the board of directors, board body. It depends on what regulation you're looking at, but they're the board. They're the creators of hospice. Dr. Levy, it's his hospice, and this is the statements. These are the statements that he's come up with that explain what he wants, where he wants hospice to go, and how he wants the patients to be treated. So I'm going to read it and break it into increments so that I can explain the importance of it and hope that you understand and can wrap your hospice heart around the mission and vision statement. Phoenician Hospice is an interdisciplinary team that will provide quality, safe, and innovative end-of-life care to individuals facing a life-limiting illness. So let's back up. Interdisciplinary team is what hospice is. Hospice is all about team. There's a team that provides care to hospice patients and their caregivers and their families. There's the medical director, of course, there has to be, or the attending physician, whoever the patient chooses. There's the nurse. There's a social worker. The social worker is there for the emotional and mental support and to offer suggestions that they know just about everything that the community has to offer. And there's a chaplain for spiritual and emotional and any kind of uplifting care that they can give. So interdisciplinary team is what hospice is. We're one of the few out there that still do interdisciplinary and take it seriously. We see the patients and we speak to the families and caregivers. Provide quality, safe, innovative end-of-life care. Quality is what hospice is all about. Quality is what is in the regulations, this book that Medicare has developed for hospice care. Quality, safe, it's all about safety for the patients, but also safety for the clinicians and all of us. It's about safety for all of us. In an innovative end-of-life care, it's not, that's the way we always used to do it. We always did it that way. Well, now research has since shown that there's better ways to provide this quality, innovative care. It's called evidence-based research. How do we make the patient comfortable? There's several ways that you can make a patient comfortable. Repositioning, room temperature, lighting, music, TV, whatever the patient desires, besides medications. All of that works together. So innovative, evidence-based end-of-life care. Phoenician Hospice provides a full continuum of clinical, spiritual, and emotional support and care that optimizes comfort and dignity, which allows for timely communication and patient access. So we discussed the clinical, spiritual, and emotional support given by all of the team. That optimizes the comfort of the patient and of the caregivers and family. We provide all this care with dignity, with privacy, with respect, with compassion. And the timely communication is not just the nurses, the social workers, the chaplain, the CNAs, the doctor, not just them communicating with the patient or the caregiver. It's all about also allowing time for the patient and the family to communicate, because if that patient is comfortable, if we get that patient comfortable, then they can spend quality time. There's that word again. They can spend quality time with their family and loved ones. They can let their family and loved ones know how they feel, but also what they wish to have done, how they wish things to be handled, and it gives them time to do that. That's the mission statement. The vision is that Phoenician Hospice is dedicated to the provision of comprehensive, quality, patient-centered care that is focused on each patient and their family's unique needs and palliative outcomes. There's that word quality again. Comprehensive because it's for the patient head to toe, spiritual, emotional, mental, physical, the nurse, physical, our hospice aides come in and help with bathing and needs of the patient. And it's all based on patient-centered. What does the patient need? And the family's unique needs, so that we have good outcomes with this patient. I just think it's important to go over the mission and vision statement and break it down and explain that this is what Phoenician Hospice is all about. Quality, patient-centered, family-centered, focusing in on what the unique needs are. Next, I would like to go over a bit of the history of a hospice. It has a vast history. The word hospice is derived from the linguistic root of hospitality, and that goes back to medieval times. I don't know if I pronounced that right, but we'll work with it. It's a place of shelter and rest for the weary or ill travelers. So bringing that forward, then there was the hostels for those hikers or bikers that are going cross country or many, many miles. They are able to stop at hostels and rest. And so it's a derivative of that, not hospice, but of the word hospitality. And then bringing it forward even further, it was applied as hospice for the dying patients, for the care of the dying patients. And this was developed by Dame Cicely Saunders, and she began her work with the terminally ill patients in 1948 and eventually created the first modern hospice, St. Christopher's Hospice in London. Dame Cicely started her career, well, first she's a dame, so that means she's of wealth. She became a social worker, and she was caring for the ill, but she realized that the patients that were ill and dying were being forgotten or not really cared for. They were in pain, but they weren't being treated for the pain. They were dying, and there's nothing more we can do for them. So she didn't really care for that. She wanted the doctors to give them something for pain, but the doctors said this medication could be used better for those that we can treat and make better. So she became a nurse, thinking that that would get her further in helping them. Well, it did. She learned a lot. She learned about the disease processes and the dying process, which she'd already experienced with the patients that she cared for. But the doctors still pushed back on that, so she became a doctor. and then she could prescribe those medications that those patients needed to make them comfortable. And she could educate the families so that they understood what their loved ones were going through. In 1965, Florence Wald, who was the dean of Yale School of Nursing, invited Dame Saunders to become a visiting faculty member and to give lectures. And it went over like a wildfire. It exploded. And so in 1969, we're going to fast forward, 1969, Dr. Elizabeth Kubler-Ross writes on death and dying and the 5 steps that terminally ill patients will go through: bargaining, anger, sadness, negotiating. I'll do if you do this, then if you make me better, I'll do this. There's those steps, and they don't go through like step 1, step 2, step 3. They can go back and forth. They can hit one and then go back to hit another one. Excuse me. So anyway, that was Elizabeth Kubler-Ross. In 1974, Florence Wald, the dean of Yale University School of Nursing, along with 2 pediatricians, opened the first hospice in the United States, and that was the Connecticut Hospice in Bradford, Connecticut. 1982, up until that point, hospice was pretty much volunteer. People volunteered to take care of them. It wasn't covered in any insurances. The wealthy would pay or donate money, but it was pretty much all volunteer. In 1982, Congress discovered or opened their eyes and saw hospice is spreading, and yet there's no regulations and there's no funding, and yet most of the people that are dying were elderly and on Medicare. So they created the Medicare hospice benefit, and when they accept the Medicare hospice benefit, Medicare Part A is no longer being used. Instead, the hospice benefit is being used. And that's the way they decided to make that work. In 1984, JCAHO initiated hospice accreditation. JCAHO is the Joint Commission of Accreditation, and they're more known now for hospital accreditation than for hospice, but they still accredit hospices. There's also CHAPS, and there's 2 new ones out now. We're accredited by CHAPS, Community Hospice Accreditation Partners. And I say partners, even though we pay a lot for them to come in and do their surveys and find errors and areas that we could improve upon, or where we've neglected or not done. By them finding that, we can improve and get better care. So that's why the accreditation is so important. In 1995, OIG, the Office of Inspector General, did some investigations on hospices, because now hospices are getting paid by Medicare, and they found waste and abuse in 5 states that they investigated. That was California, Florida, Illinois, New York, and Texas. And it was waste, abuse, and fraud. And so that started their wheels turning, and they are rolling today. So there's this is the Medicare regulations book. It has Medicare regulations. It has Arizona Department of Health Service regulations, which coincide with Medicare hospice regulations. And it also has the conditions of participation. That's how we do our work. On what condition can we do it? This is how. So OIG now investigates daily, and they're looking for ways of bringing money back into Medicare related to fraud, abuse, neglect, and other areas of misuse of funds. In 2003, National Hospice and Palliative Care Organization celebrated its 25th anniversary, and that's a big deal. They are our advocates in the government. They are the ones that will go and talk with Congress, talk with the representatives, discuss the regulations, and get them changed, the hospice regulations, so that we can operate as hospice and not a hospital, because there's a complete difference there. In 2006, Dame Cicely Saunders passed away. It was a great loss. 2010, we honor veterans. "40 years of hospice care in the United States" was celebrated, and we honor veterans, and we're part of the We Honor Veterans campaign. And there's several stages, 4 stages that you go through, and each one requires more and more community involvement and involvement with the VA. So hospice has come a long way. Here we are today, and they're still changing regulations, and they will on a daily basis or a yearly basis, and we will comply with those regulations. I mentioned conditions of participation. The conditions of participation explains, it'll have the regulation, and then here's the conditions. This is how you will meet the regulation, or this is what's expected for you to do to meet these regulations. It's intervention, step by step. It's the conditions of, is the patient appropriate for hospice? What conditions can we admit a patient? What conditions can the nurse see the patient in? What conditions can a patient have general inpatient care, respite care? We'll address those later on. These are just lead-ins so to keep your interest going. Medicare regulations and OIG investigations, they create the standards of care, they create the regulations, but it's all about patient safety. So from the very first regulation, which involves the board of directors, through to the very end of all these regulations, it's all about the patient. You may not think so, because it's a regulation. It's regulating what the directors can do. It's regulating what the administrator can do. It's regulating what the QAPI person can do. Regulating the nurse, the social worker, every person involved, every discipline. There's regulations for it. But it's all about patient safety. Why would someone answering the phone have anything to do with patient safety or patient care? Well, what about tone of voice? What about knowledge of hospice? What about being able to answer their questions or knowing the right person to direct that call to, so that they can get the appropriate care or needs met? So it's all about quality improvement. It's all about patient-centered care, family-centered care, and education. And that all drills down to safe care with compassion, privacy, respect, compassion, all of those terms, all of that goes along with hospice. I mentioned this book, the regulations. There are regulatory requirements, and they are federal, Medicare. They're the top of the list. They are the ones that Congress comes up with these regulations that we must meet. It goes through the whole process. It isn't just that they say, here's a regulation. It goes through the whole process of research and why. And during that process, that's when an HPCO, National Hospice and Palliative Care, will step in and discuss with them, write letters, maybe ask us to write letters, and we will, and give our opinion as to why this is either a good regulation or one that needs to be looked at again and perhaps changed or passed over as a regulation instead of being brought in as new. state, Arizona Department of Health Services, every state has regulations for hospice. Each state has their own. And I'm going to say that 99% of them actually do match the federal regulations. They cannot be less than or more lenient than, but they can be more stringent than. Most of the time, they are congruent. They work with, because the federal government's already written the regulations. Why would they want to come up with a regulation to make it even more? Why would they want to do that? We have a whole binder full of regulations that the federal government wrote. So the state says that looks good to me. And 99% of the time, that's the way it is. The VA, Veterans Association, they have a hospice in the VA. The interesting thing is with the VA that if the veteran also has Medicare, they also have the VA insurance, then they can come on hospice using the Medicare hospice benefit, but they can also continue using the veterans benefit for aggressive care. So they have maybe the best of two worlds, because they can continue aggressive care, yet get the comfort care, and yet get that cancer, continue with whatever treatments they're getting, which is aggressive treatment. That's the only insurance that allows that, and that's with our veterans. CHAP, Community Hospice Accreditation Partner, Community Health Accreditation Partner. I discussed that. They're our accrediting agency, and they come in every 3 years and do a head-to-toe survey, and they go out with the various disciplines to make sure that they are doing safe care, safe treatment, infection prevention type treatment, bag safety on their nursing bags or their skilled nursing aid bags. They are looking at everything, our documentation, everything, right down the line. Our hospice patients require a lot of medical equipment. Most of them do. They require a hospital bed. Maybe they require oxygen, maybe over-the-bed tray or a bedside commode. There's a variety of shower chair. We supply all of that. The hospice, the Medicare hospice benefit covers all of that. So none of that is expense to the patient or their family at all. There is a Medical Device Reporting Act, number 21 CFR 803, that covers the breakdown of this equipment. If there is a death, serious injury, any errors, product quality issues, or therapeutic failures, these must be reported. Now, if something is not functioning properly, but an injury hasn't occurred, it would be reported. The staff member would report it to the agency. We would call in Avanti, our durable medical agency that we get the equipment from, the DME equipment, and they would go out right away and look at it, fix it, or replace it. Usually they replace, they don't try to repair. If any of those areas, death, serious injury, any of that has happened, then we report. Avanti has to report. They report to the government. They report to the Arizona Department of Health Services. They report to the federal government that governs this equipment, because it has to be safe. We cannot allow our patients to be injured due to equipment breakdown. It's all about the safety. With that, are there any questions?